Good evening. I am Brother Langston Smith, Deputy Surgeon General for Dental Health. Welcome to the Surgeon General's webinar series of Alpha Phi Alpha Fraternity Incorporated. On behalf of our General President, Brother Willis Lonzo III, our Surgeon General, Dr. Jeffrey Sterling, and the board of Alpha Phi Alpha Fraternity Incorporated, I welcome you. Our topic for tonight: the do's and don'ts of dental pain. All too often, many of us don't consider a visit to the dentist until we have that wake-up toothache in the middle of the night, or we experience a swollen jaw and wonder, what could this be? You hear a crack while chewing and you're puzzled. So you ask yourself, why does my tooth hurt? Why is this tooth hurting? Why is my jaw swollen? What can this be? And more, what can I do about it? Of course, the answer we have taken in the past has been, oh, let's take a pain medication for it, rinse it with warm salt water, put an aspirin on it. But more importantly, visit your dentist. Pain is the most common complaint in clinical dentistry. It can affect every aspect of your life. Tonight, many aspects of dental pain will be discussed with you by our distinguished panel. They will define just what dental pain is. They will look at several sources or causes of pain, and will discuss the management of pain. But first, a few housekeeping notes. Please mute your devices so as that they don't interfere with the presentations of the panelists. And secondly, we will have a question and answer session after the presentation. So please place your questions in the comment space and we will try to get to all of those that are presented. Our panel tonight is a very distinguished and acclaimed team of dental professionals with outstanding backgrounds in clinical and academic dentistry. I will introduce them alphabetically. Dr. Jay Anderson. Dr. Anderson is a graduate of the University of Kentucky College of Dentistry, and he received the Master of Health Sciences Administration and the Master of Public Health from the University of Michigan. He has served as the Chief Dental Officer of HRSA, and is currently Dr. Anderson is the Dental Director of One Community Health Federally Qualified Health Center in Sacramento, California. Dr. Christopher Chance. Dr. Chance is a board-certified pediatric dentist. He received his dental degree from the University of Kentucky also, and completed residency in pediatric dentistry at the Case Western Reserve University School of Dental Medicine. Dr. Chance is in private practice of pediatric dentistry along with his wife at the Oaks Point Pediatric Dental Center in Houston, Texas. Dr. Dana Jackson. Dr. Jackson is Chair and Program Director of Oral and Maxillofacial Surgery, Howard University Hospital and College of Dentistry. He is a diplomate of the American Board of Oral and Maxillofacial Surgery and a fellow of the American Association of Oral and Maxillofacial Surgeons. He also serves as associate professor at Howard University's College of Dentistry. Dr. Dontra Scott. Dr. Scott received his dental degree from Howard University College of Dentistry. He completed a general practice residency at Brock's Lamberton Hospital in New York City and his endodontic residency at New York University. He is a board-certified endodontist and diplomate of the American Board of Endodontics. Dr. Scott is in private practice of endodontics at Heights Endodontics in Houston, Texas. Dr. Justin Watson. Dr. Watson is a commander in the United States Navy and serves in the Navy Dental Corps as an operative dentist. He earned his dental degree and the Master of Science degree in Cardiology and Operative Dentistry at the University of Michigan. He has served as the Director of Dental Services at Naval Hospital, Oak Harbor, Washington, and is currently the Dental Department Head at Navy Readiness Training Unit, Bangor in Washington State. We will begin our discussion this evening on the topic, dental pain defined, with Dr. Anderson, and then move into a discussion on pediatric dental pain with Dr. Chance. Following Dr. Chance, we will get a look at several causes of dental pain with Dr. Watson, and then how we manage dental pain with Dr. Scott. We will wrap up our discussion with a discussion of pain associated with post-surgical procedures, short discussion on non-dental pain that may mimic dental pain with Dr. Jackson.
Yeah.
Welcome, panelists, and thank you for joining us tonight. We are looking forward to your presentation, and we will now begin our discussion with Dr.
Good evening, brothers. It's a pleasure to be here. My task is to help us define pain and offer different perspectives on how pain is defined. Is my slide showing? Cool. Right. In defining pain, the new definition, according to the International Association for the Study of Pain, describes pain as an unpleasant sensory and emotional experience associated with or resembling that with actual or potential tissue damage. It's an adverse sensory and emotional experience typically caused by or resembling that a potential tissue injury. Pain is a signal in your nervous system that something may be wrong. It could be a unpleasant feeling such as a prick, a tingle, a sting, a burn, or an ache. Pain may be sharp or dull. It may come and go, or it may be constant. You may feel pain in one area of your body, such as your back, abdomen, chest, pelvis, and in our case, in the oral cavity. There are two types of pain, acute and chronic. Acute pain usually comes on a sudden basis because a disease or injury or inflammation, as a result of a disease, injury, or inflammation. It can be often diagnosed and treated. Acute pain usually results from a specific injury, disease, and or inflammation. It generally comes on suddenly, for example, after physical trauma or surgery. It can be accompanied with anxiety and emotional distress. Normally, acute pain is a protective response to tissue damage resulting from injury, disease, overuse, or environmental stresses. The cause of acute pain can be diagnosed and treated. The pain is usually self-limiting, meaning that it's confined to a given period of time. However, acute pain can progress to a chronic pain. Chronic pain is a medical disease that can be made worse by environmental and psychological factors. Chronic pain persists over a long period of time, and it can be challenging to manage. People with chronic pain often suffer more than one painful condition. They often have increased risk for developing problems with physical function, cognition, and emotional reactions. There may be common mechanisms that put some people at higher risk for developing multiple pain disorders. It is not known whether these disorders share a common issue. Pain is an unpleasant signal that sometimes hurts. It's a complex experience differs greatly from one person to another. One person's pain may be another person's discomfort. Pain warns you when something is not quite right in your body. There are very few natural pains that do not indicate that something is wrong. Pain is often a debilitating symptom of many diseases and is considered a disease itself when it persists beyond recovery from the injury or illness. Pain goes away on its own with treatment, with or without treatment, but it can persist and develop into long-term chronic pain. Millions of Americans have pain every day. Like me, when I get up in the morning, my muscles tighten up and my knee pops. I guess that's just because I'm old. Pain is not always curable, but there are many ways to treat it. Treatment depends on the cause and the type of pain. There are drug treatments, including pain relievers. There are non-drug treatments such as acupuncture, physical therapy, meditation, and sometimes surgery. How's pain diagnosed and treated? Pain is mostly a subjective experience. There's no way to objectively measure pain. Only the person experiencing the pain can tell you how much pain they feel. Pain is always subjective. Each individual learns the application of the word through experience related to an energy early in life. Pain is that experience we associate with actual or potential tissue damage. It unquestionably is a sensation in a part or parts of the body, but also it is always unpleasant and therefore an emotional experience. In my clinic, we use a metric of smiley faces going from happy face to really distressed face. And it coincides with a scale of 1 to 10. 0 would be, 0 to 10. 0 would be no pain, I'm happy. 10 would mean I am really, really hurting and you need to do something for me, doc. I want to talk a little bit about mouth pain, what we experience in the dental clinic when patients come in. Pain can exist in the roof of your mouth, inside your cheeks, the back of your mouth, the gums, the tongue, and any of your teeth. Common causes of mouth pain. Trauma is the #1 cause. Dry mouth is another cause. Canker sores, fever blisters are very painful. Herpes simplex appears on the tongue and the throat, which is also a stinging sensation in your mouth. Some diseases like oral candidiasis, which is a fungal infection, can cause your mouth to tingle. Lichen planus is another autoimmune disease that can cause pains and even sores. Human papillomavirus, or HPV, is also can cause pain in the oral cavity. Oral cancer often is not painful in the beginning, but becomes very painful and serious over time. Gingivitis is when your gums are inflamed and cause pain. When your gum disease progresses, it becomes periodontitis, and your teeth may get loose and be very painful as well. Toothaches, we're going to have discussions about toothaches later in this presentation. Prevention is the best cure. Often we put off taking care of ourselves until pain manifests and reminds us that we need to do something about it. So often make sure that you go to your dentist, have regular checkups, and if there is a pain, get to your dentist as soon as possible and don't expect the pain to go away on its own. Do's and don'ts of dental pain, old wives' tales. When I was a kid, when we had a toothache, my mom would first try to figure out what's going on. She would have me drink cold water. Sometimes it would go away and sometimes it wouldn't. Here's a few examples of home remedies that may or may not work. These remedies are usually temporary solutions and do not replace the advice of your dental or medical provider. Cold compress, putting a cold bag. I usually use a bag of frozen peas. I recommend that to my patients. Place that on the area of pain, and that desensitizes the area. You leave it on for about 10 minutes and take it off 10 minutes. Using tea bag in an area where you may have swelling. The tea bag pressure often allows for temporary relief. Cloves. This is one of those old remedies that probably came from Africa. They would mash the clove in the paste and put it on the tooth or the area that's been bothering you. And the clove itself can cause a little stinging, but it does offer some relief. Thyme. This is one of those things where you just run into the cupboard and grab something that has been used for many hundreds of years. You use the thyme oil and make a mouthwash by adding a drop into a glass of water to make a mouthwash. Warm salt water often offers relief from gum pain. Aspirin. Back in the old days, they used to say, put an aspirin on top of a toothache and the pain will go away. Little did people know that by swallowing the aspirin, that's what's causing the pain relief. So do not recommend placing aspirin on top of any lesion. It should be swallowed. Using Oragel. A lot of my patients, that's their first resort to dealing with pain, and it does offer some relief, but it does not offer a cure. Oil pulling is a controversial process where it came from India. There is a mouthwash that you would use, placing coconut oil on your gums, and that will often relieve pain. These are some references we can use. Thank you for your time. Langston, I think you're muted.
Thank you, Dr. Anderson. Yeah, I was muted. And now our next presenter will be Dr. Chris Chance on pediatric dental pain.
Good evening, brothers and guests. I'm going to talk a little bit about pain management in pediatric dentistry. So we're going to have a little bit of discussion on what is pain and who's most at risk. How do we assess pain in pediatric patients, and also the pain management procedures. A lot of what Dr. Anderson was saying, I'm going to piggyback on a little bit, and then we'll move forward with a little bit of additional information. Again, as Dr. Anderson said, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And so infants and children are more sensitive to pain because they do not have the cognitive skills to modulate that pain. So like for me personally, if I were to, let's say, get a vaccine or need something at my my physician's office that I believe may cause pain, I either pinch on my own fingers or against my leg to kind of help modulate that pain I'm going to feel, that I feel is greater. So kids may not have that ability or develop those abilities yet. Also, the pain pathways are a little bit more poorly developed, and also allows full transmission of pain. Some patients who are more higher risk are those who may have history of prematurity. They may be infants or young children. Also history of uncontrolled procedural pain in the past, or also frequent medical intervention. Past physical, sexual, or psychological abuse can cause future susceptibility and higher risk for pain. So some common causes for oral pain in kids. One of the most common ones we typically get are teeth coming in or eruption of the teeth, teething, dental decay, cavities, sores in the mouth like ulcers, burns, abrasions, cuts. Also, like food stuck between teeth. Maybe having difficulty flossing them out. Tooth trauma, inflamed gums, inflamed gingiva because of poor oral hygiene. Actual dental procedures, it can cause a little bit of discomfort as well. And some systemic diseases, hand, foot, and mouth disease. Dr. Instant also mentioned candidiasis or thrush, and also herpes simplex viruses as well. The first sign of herpes simplex type 1 is usually cold sore, which causes what's called gingival stomatitis. It's just really fiery, bleeding gums in young kids. They usually get it just from being passed around toys and things like that, and germs in the mouth during daycare and what have you. Temporal mandibular disorders, that's jaw pain. Injuries, maybe falling down, hitting their jaws or anything like that, and also overcrowded teeth, just to name a few. Some effects of improper management of pain or not managing pain soon enough, it can actually change the architecture of the brain of a child. And so it can cause increased sensitivity to pain in the future because it affects their sensory information structures like the dorsal horn of their brainstem in their brain. So if a child is in pain, it's very important to get that seen. Allow us to take a look at your child's teeth or children that you may see, that their teeth and their mouth or their gums, to make sure that they're not in prolonged pain, because it can affect how they basically experience pain in the future. Also, significant stress can cause more complications after a procedure. So one thing in pediatrics that we tend to want to make sure we do is make sure that stress is down, anxiety is down as much as possible while we're doing these procedures. Some pain assessments. I know Dr. Ensign mentioned this as well. This is the Wong-Baker FACES pain scale. So this is the one that was mentioned in regards to what the child's face may look like if they're in pain. I typically don't use that because sometimes it's very difficult for a young child to assess their own pain in a sense of what a face will look like or what a number would look like. I may use a similar pain assessment as this one. It's a visual analog scale pain assessment for a little bit older patient, maybe middle school, high school. It's more so a 0 to 10 pain scale, 10 being the worst pain you've ever felt in your life so far. How does this tooth or this sore feel to you? Also, I assess pain. Let's say I'm doing a procedure, and in regards to the faces, legs, arms, crying, consolability scale. So basically what this is me observing the patient and seeing what I'm doing and how it's affecting the child. So let's just say I am in the process of numbing, right? So put a little jelly next to the gums, and then I use a needle, which I actually never say in front of the patient, but I use a needle to kind of inject some numbing, which I'll talk about a little bit later. And I can tell that the patients are maybe a little bit squirmy during that time, maybe whining just a little bit, but not jerky or anything like that, meaning that they may have some discomfort, but it may not be extreme pain. If a child jerks out of the seat or kind of unconsolable crying, I know I'm likely causing discomfort past what they're willing to handle. And so I have to correct that in some way. There's some pain management procedures, non-pharmacologic, does not require medication, pharmacologic, which does, behavior management, and also dental treatment. So some non-pharmacologic pain management, a couple that we use a lot in pediatrics is distraction. The hypnosis part, that's a little bit of maybe not as much happening in pediatrics or so, and maybe not happening as much in adults either, but is an option. But the distraction is huge. We use TVs, televisions on the ceiling, televisions on the wall. We use music. We tell stories while we're doing treatment. I use numbers a lot, like counting. So if I know the child is a little bit more squeamish in regards, or like squirmy around trying to do work, and I say, okay, I have 10 seconds of this left. Let's count together. They're going to give patients a trust to say, I know he's going to stop in 10 seconds because he said he would. And then some offices use therapy dogs and other means of allowing patients to feel calm and relaxed during procedures. Coaching is very important. You want to be able to give patients, especially young kids, just positive self-statement. So instead of me saying to a young child who may be moving while I'm doing treatment, filling, crown, extraction, what have you, instead of saying, stop moving, stop doing this, I'm saying, thank you for not moving. Thank you for holding still. Thank you for keeping your mouth open. Thank you for doing so well. And it's kind of redirecting a young child to do the behaviors I want them to, versus telling them not to do something that I don't want them to. So it kind of gives them a direction versus just saying no. Because if you just say no, they won't know what is right. If you tell them what's right, then they'll try to follow that as much as possible. Also, sucrose, breastfeeding, skin to skin contact, a lot of that scenario will be more so in young infants. So if we're doing a procedure like what's called a frenectomy or frenulectomy, which basically a patient may have a tongue or lip tie, it's very difficult for them to latch while nursing breastfeeding. Sucrose, which is sugar water, can be given to young patients under 6 months old. And it kind of has a similar pathway or similar effect as an opioid without the opioid issues. But that pathway can help with making them feel more relaxed, but also allowing less pain during that process, because we typically cannot use numbing or topical gels because for fear of toxicities. Cooling the injection site before doing any particular numbing. And also, as Dr. Innocent said earlier, using like cold compress. He was talking about frozen peas. Anything like that can also be used to help with discomfort. And then vibration. Whenever you're yourself being seen by a dentist and you have to be numb, a lot of times what we do is we shake the lip or shake the cheek. When that does kind of redirect the focus to a different place, so the actual discomfort of having a numbing injection may not be as much. Okay, so some pharmacologic pain management. So topical anesthesia, the topical gels that we typically place before doing a numbing procedure. It helps in a twofold. It helps because it helps numb the area, but also when the patient knows that jelly is supposed to make the next part, which is the numbing, more comfortable, then they're anticipating less pain. So they're more relaxed and they're less anxious, which will help with pain. It's not really great for kids under 2, especially if it has benzocaine, because that can lead to toxicities. And then the local anesthesia, the actual numbing technique, there's a lot of different options that we can use as dentists, but in pediatrics, typically use what's called lidocaine or articaine. Now, some pharmacologic pain management at home, ibuprofen, acetaminophen, so like children's Motrin or children's Tylenol can be used. Ibuprofen typically first line of defense in regards to discomfort. It deals with anti-inflammatories. And then what we typically also recommend, which I'll talk a little bit about in the next slide, is alternating the ibuprofen and the children's Tylenol. So let's say you take ibuprofen, wait 3 to 4 hours, take the next dose of children's Tylenol, and then alternate those. They can work as well as, let's say, like an opioid or narcotic for a young child, but without any of the other issues. We do not typically use aspirin, codeine, or opioids for kids due to toxicities and their dangers. This kind of talks a little bit about what I was saying earlier about alternating ibuprofen or children's Tylenol. Behavior management is very important because we want to basically reduce anxiety, because anxiety can cause a heightened sense of pain. So we want to establish communication when we're doing that. We want to alleviate fear and anxiety, deliver good care, build trust, and also have kids have a positive attitude. So I do what's called tell, show, do. I tell the patient what I'm going to do in their own way. I show them exactly what I'm going to use, and then I do it. I build that trust. Nitrous oxide, which is laughing gas, is another option to use. I use that quite a bit. Helps relax the patient, reduces the anxiety, which will reduce pain. And I also use voice control. When I'm really excited, I'm very, I move my hands, I lift up a lot, I have my voice go higher. But when I'm doing treatment, I need for them to be calm. I lower my voice and I am more calm and more soft, and a little bit more direct, so they can be a little bit more relaxed and calm and hear what I'm saying. Okay, lastly, the actual dental treatment of pain. And so it was mentioned a little bit by Dr. Anderson in regards to tooth sensitivity. Also, what's called reversible pulpitis and also irreversible pulpitis. Tooth sensitivity is very mild typically. Slight discomfort eating, drinking cold foods, maybe with brushing and flossing. For me personally, I cannot eat into an ice cream. Some people can like bite into an ice cream pop. I can't do that. My teeth are kind of too sensitive for that. So I use fluoride rinses, or now you can use hydroxyapatite rinses, things like that does not have fluoride in it. You may need to use better brushing or flossing techniques to reduce inflammation. Sometimes these sensitivity may need fillings or crowns in the future. Reversible pulpitis, is basically it's more significant discomfort with like a stimulus like cold or hot, things like that, sugary items. And so the pain leaves once the item is removed, and then it can be fixed from like fillings, crowns. In young children in baby teeth, we do what's called baby root canals or pulpotomies. If the cavity, let's say, reaches the nerve, we need to take away some of the affected nerve, put medicine into the tooth, and then put a crown over top of it. Irreversible pulpitis is basically when there's extreme pain, pain that wakes your child out from their sleep. Also, it doesn't go away when the stimulus is removed. Very achy, lasts a while. That scenario, we usually do a root canal or having to remove the tooth. So ultimately, what I really want to drive home is having your children see the dentist. If they haven't seen him in 6 months, him or her in 6 months, then need to schedule that appointment. Want to make sure prevention is the key. And also, parents and guardians, please don't pass on a little bit of fear. Try their best not to pass on a little bit of fear, anxiety of the dentist to your young ones. As we know, if they become anxious, then they become a higher risk of having discomfort. So I want to thank you for your time. We appreciate you having you. Appreciate you having me. And next will be Dr. Justin Watson.
Dr. Watson, you are muted. Everything you had said was muted.
All right. Am I back with voice? Yes. And share screen. All right, am I good to go now, Dr. Langston?
Good to go.
No? Voice? Should be good. Good. All right. Got it. All right. I'm sorry about that. Let's go. Today we're going to talk about tooth sensitivity and temporal mandibular joint disorder. So today, tooth sensitivity, it can be caused by lots of things, but specifically today, I'm going to talk about tooth sensitivity that's not related to decay or infection or a cracked tooth or something more common, where like you're drinking some cold water, having a popsicle, and you get a cold zing, and that zing that just lasts a couple seconds. If it lasts for a minute and you're like, oh my God, this is still bothering me, we may have something more serious than just a simple fix like gum recession. Gum recession is one of the most common causes of tooth sensitivity. It's caused by numerous things. One is just getting older. As we age, our gum starts to recede from our enamel. And if we had the saying, if you've ever heard the saying before, that person's long in the tooth, it's not that that person's teeth are growing longer, it's that their gums are receding, making it appear that their teeth are longer. Other causes for gum recession is your brushing technique. If we have a very aggressive brushing technique where we're doing big back and forth movements with the toothbrush, that is very abrasive and will cause your gums to recede faster. Abrasive toothpaste, like whitening toothpaste. Um, my background as an operative dentist, we look at materials and we look at disease processes that occur, like tooth decay and recession. Whitening toothpaste are not good for your teeth. And the reason they're not good for your teeth is because they're very abrasive. It's like taking wet sandpaper to your teeth every time. And so you're not really whitening your teeth with like a bleaching agent. You are abrading your teeth with sandpaper. Toothbrush firmness. If you are using a soft toothbrush or an extra soft toothbrush, that's great for your gums. It may not feel like you're cleaning your teeth as well, so it may take an extra couple brush strokes, but a hard toothbrush, although it cleans your teeth very effectively and quickly, it will cause your gums to recede more quickly. A big reason for gum recession that a lot of people don't understand is orthodontics. If you have a history of braces, sometimes your teeth can get, and the gums will reset according to where the bone lays and not where your teeth are. And so, in the cases of recession caused by orthodontics, you cannot really do too much to treat those areas except mitigate the loss of gums by um, not having an aggressive toothbrush technique, using a soft or extra soft toothbrush, or even electric toothbrushes. The second cause tooth sensitivity is abrasion, abfraction, erosion. All these things are um, similar in the fact that it's a loss of tooth structures, a loss of enamel that are caused by either clenching or grinding your teeth or having an acidic diet. And we could talk about that later. So brushing technique can cause abfraction if it's a very aggressive brushing technique with a very firm or hard tooth bristle brush. Your diet, an acidic diet, can cause erosion, and with combination of abrasion. Clenching or grinding are theorized to also cause abfraction, and I will show some pictures in the next slide of what these abfraction lesions look like. So what are some treatment options for recession? So starting with the least invasive to the most invasive uh, is your brushing technique. So it's best to use, and you probably heard this before, is small. I recommend an electric toothbrush because electric toothbrushes move on a very microscopic level, and that microscopic level is less abrasive towards your gum line, and it gives you an effective um, brush stroke for cleaning. We talked about this earlier, is toothbrush firmness. You should never use a hard bristle toothbrush. Yes, I know it feels great. They clean really well, but they will destroy your gums at the cost of having your teeth feel cleaner more quickly. Desensitizing toothpaste. Now, this is Sensodyne toothpaste. There's lots of different brands out there. Feel free to try whatever desensitizing toothpaste you have at the store. But these toothpastes typically take 1 to 2 months for them to take full effect. So be patient with them. That are desensitizers that you can use in the office by your dentist. this particular product. It's called Gluma, and you will get relief from this almost instantly. However, the effects typically only last 1 to 3 months, and there'll need to be, in addition, coatings with it. Now, fillings. This is a picture of abfraction, or some people may call it abrasion, but what's happening, we're missing tooth structure. Our root has been exposed. And so if your teeth look like this, excuse me, if your teeth look like this and you have no sensitivity, you don't need to do anything. If your teeth look like this and you have sensitivity, you could just use the Sensodyne toothpaste or Gluma and move on. If your teeth look like this and it's an aesthetic concern, something like fillings to cover them up will address your aesthetic concerns, and it will also address your sensitivity concerns. And the most aggressive treatment you can have for gum recession is gum grafting. I don't have any pictures of this on here, but I will tell you it's not a very comfortable procedure, but it's often necessary to slow down the loss of soft tissue around your teeth, but it's not always a good indication for it. So if you have a history of braces, doing a gum graft will not hold very well relative to someone who has lost gum tissue because of brushing too hard. And at the end of today's presentation, we will answer the questions in the comment section. Moving on to temporal mandibular joint. So I have patients come into my office every day and they say, "Oh, doc, I got TMJ. It really hurts." And my comment to them, and I smile when I say it, is like, yeah, you have two TMJs. Your temporal mandibular joint, everybody has. It's where your jawbone connects to your skull bone. What most people are talking about when they're in pain and they say, "Doc, I have TMD. I have temporal mandibular disorder," and disorder has different symptoms. So part of those symptoms are pain or tenderness to your jaw. You wake up in the morning and your jaw just hurts. And it could be your left side or your right side or both. Some people describe their TMD as aching pain around the ears. I have difficulty chewing. The muscles in my face, they really hurt. In extreme cases, a patient jaw might lock and they can't close it themselves. Going to your general dentist, they can put it back into place and it will resolve the issue for the moment. Popping and clicking. Popping and clicking is something that shouldn't concern you unless it's associated with pain. Uh, a lot of our joints pop and click, and there's not a whole lot you can do about it. And with your TMJ, your temporal mandibular joint, 33% of the population has popping and clicking. And if they do pop and click, you should avoid the pops and clicks. Don't act like it's your knuckles and you crack them all the time for relief. This will lead to arthritis, or it will lead to increased likeliness of having a pain or discomfort with your temporal mandibular joint. So what are some causes? Big cause for TMD is stress. This is people that are in stressful situations sometimes will get this, and it's typically manifested by clenching or grinding your teeth. Personality types. So a type A person is more likely to have temporal mandibular disorder than a type B person. And that mainly has to do with how they deal with stress in their life. And then sometimes we just don't know why. A patient may say, I don't have any financial problems. I don't have any relationship problems. I've been working the same job for the last 20 years. My jaw just hurts. So clenching and grinding, you can do this at night, which is a very hard thing. People do it during the day. And if you clench or grind your teeth during the day, that is a behavioral change that you need to address to stop the symptoms of the pain or discomfort. taking your cell phone or your watch and setting a timer for every 15 minutes and let it go off and ask yourself, did I clench or grind my teeth during the day? And you may find yourself clenching or grinding your teeth during the day. Another time people clench or grind their teeth and don't realize it is when they're sitting in traffic. And I explain to patients when they're in the chair that your muscles in your face were created for a particular manner, and that is to open and close your mouth and to chew food and to speak. And your teeth should not be in contact for more than about 5 to 6 minutes a day when you're eating. When right, your teeth should not be touching. A natural, relaxed position, your teeth have something called a leeway space, and that leeway space is typically 2 to 3 millimeters. And every time you load those teeth outside of those normal parameters of 5 to 6 minutes, you're you're increasing the risk of having some type of either musculature pain or tooth pain associated with it. Another analogy to think about the muscles of your face is when someone clenches or grinds their teeth in a static position, is asking your teeth to do a lot outside of its normal job of just opening and closing. So if I gave you a 5-pound weight and asked you to curl it with your right arm 4 or 5 times, you say, yeah, easy, no problem. But if I gave you that same 5-pound weight and I asked you to do a half curl and just hold it there, probably in about 5 to 10 minutes, you would start to feel that burn. And that's because that bicep wasn't made to hold a static load. It was made to be in a extension flexion mode. And same with your jaw. You should not hold a position for a very long time. And that's why you have the muscle soreness, the tightness in your jaw muscles. So what are our treatment options? If you're clenching or grinding your teeth, well, you need to decrease use. So habits like chewing gum or diet, chewing beef jerky, things like that are really going to overload those muscles in your face. Stop doing it. Give it a break for a while. Keep your teeth apart. We talked about it earlier. There should always be a natural, relaxed position in your face where your teeth are not touching. If you're in acute pain, a pain just came on top of you, you can use heat packs or ice packs, whatever feels better. There's no hard science to which is better. It's what works for you. So you can try either or. Reduce caffeine. Caffeine will cause tension in your muscles. So my drink per day and reduce your caffeine intake. And exercise and hydrate. So this is kind of a common thing to reduce stress, right? Exercise releases endorphins. Hydration helps staying active, and drinking lots of water will help your jaw pain. We kind of talked about this already. Avoid stress on the jaw with your diet, with your habits. Avoid stress in life, and avoid is probably not the great word. Maybe deal with stress in your life, knowing that you are about to move to a new place or you are starting a new position. Not allowing that to manifest itself in a way that you start to clench or grind your teeth at night. And just this is more behavioral psychological effects of treatment that as a dentist to fix you. Posture that you have your shoulders back, you're engaging your core, because as soon as you slide your head forward, you put added stress on your neck muscles, which in turn add the stress into the facial muscles in your face, and that can cause temporomandibular disorders. So using over-the-counter medications that were talked about earlier, and also Dr. Scott will talk about in the next slides. Night guards. This is everybody's favorite thing for night clenching or grinding your teeth. Sometimes they work and sometimes they don't. There's not a great scientific correlation on if these help or if they make them worse. So if the things that I suggested earlier aren't helping you, go to your dentist and have a night guard fabricated. They have hard night guards and they have soft night guards. Soft night guards sometimes help, and sometimes they make things worse. Hard night guards, sometimes they help, sometimes they make things worse. So this is just a trial and error. And if they make things worse, stop using them. And even Botox. Botox is being used in management of TMJ because it allows those muscles that are causing you to load those teeth in an inappropriate way to paralyze them, so they're not able to be at this high strength level and make your teeth hurt because they are being loaded too highly. So those are the treatment options for your TMJ and or your TMD if you're in pain. And next, we have Dr. Scott talking about over-the-counter or pharmaceutical management of pain.
Hello, everyone. I'm going to share my screen. My name is Dontre Scott. I am a board-certified endodontist in private practice limited to endodontics in Houston, Texas. My portion of the presentation is to speak with you about the pharmacology of dental pain. You know, all the previous presenters have talked about this hurting, this popping, clicking, sensitivity to hot or cold, or even when you go to the dentist, actual pain during drilling. So I want to speak to you about how we manage pain both during and after dental treatment. So as the first presenter spoke to you guys about what is pain, he went very deep on it. I'm going to just keep it real surface. Pain is basically a signal from somewhere outside of your brain to your brain that something is not right. There are a lot of physical changes that occur in the nerve that allow that signal to be sent. But the most important thing I think the first presenter, Dr. J, spoke on was that pain is subjective. It's how you feel, and there are different levels of pain perception. Sorry about that. So once again, I'm going to speak to you about pain control both during and after treatment. And these are the things that the dentist has and you have at your disposal to help with that pain control, both local anesthetics, NSAIDs, acetaminophen, also known as Tylenol, narcotics as well, and corticosteroids. Now, the first thing I want to talk about is pain control during dental treatment. Now, this is the part no one likes to talk about. I know we all hate going to the dentist mostly because of this reason here, which is that local injection, that needle. Nobody wants to get the shot, right? I understand that. But what local anesthetics do, if administered correctly, they prevent the transmission of pain impulses to the brain. You know, over a short period of time, they pretty much block those nerves on the outside, like I mentioned, sending any signals to the brain on the inside. If your dentist has a good training background and they understand your anatomy, they should be able to administer those anesthetics effectively so that when they're drilling on your tooth, there's no pain either. You may feel the vibration or them actually pushing, but there should be no sharp signals done correctly. So what local anesthetics do, like I said, they prevent the transmission of pain. They're used during treatment. Your liver is what breaks down those local anesthetics, whether it be lidocaine, articaine. Some people who may be a little bit older may have heard of like Novocaine. Those are the same type of medications which block those transmission of pain. And epinephrine is added to these drugs to help increase how long they last in that area. So local, the don'ts is you don't want to use them if you have any allergies to sulfite, because that preservative is inside the local anesthetic. It's pretty rare, but some people do have it. So make sure if you do have it, you're aware. And as I mentioned earlier, epinephrine is added to these drugs. So epinephrine makes your heart beat fast. So if you're a cardiac patient, someone with medical history, cardiac arrest or anything of the such, you definitely want to use these precautions. So your dentist would need to know a really detailed medical history. And there is a maximum dose of 500 milligrams using most of these local anesthetics. So I usually tell my general dentists who refer patients to me, anything over 10, you might want to stop just to be safe. The most effective over time has been shown to be the NSAIDs, or the non-steroidal anti-inflammatories. What they do They work as analgesics and anti-inflammatory, so they help in multiple ways relieve a lot of pain, and also reducing your fever there. And they work by blocking an enzyme called COX-1 or COX-2. I won't get too deep on that, but that's what's happening on the pharmacological level. And they also prevent that prostaglandin production, which is also involved, like I said, as far as anti-inflammatories go. You don't want to use these type of medications if you have an allergy to aspirin. That's something you might want to know about your history. Also, if you have any type of gastric medical history, GI issues, ulcers, anything of the sort, you don't want to use these type of medications. And you can't ignore any type of other medication that you may be taking. That's why it's really important to let your dentist know if you're taking anything like metoprolol, methotrexate, any ACE inhibitors. Those type of things may interact with these non-steroidal anti-inflammatory drugs. But otherwise, they are really great at controlling pretty much all pain if used correctly. There is a maximum dose of ibuprofen, which is 3.2 grams in 24 hours. So that's about, if you look here at the picture of 200 milligram pills, that's roughly about 16 pills every 24 hours. You don't want to take more than that if you're taking over-the-counter Advil. The next drug I'm going to talk about is acetaminophen, otherwise known as Tylenol. It's a really great analgesic and also antipyretic, meaning that it helps reduce that fever that you may have. And on a chemical level, it inhibits prostaglandin synthesis, and it also has some other central nervous system interactions that have been proven, where it kind of also helps relieve pain in different, more deep mechanisms. What I really want to touch on when using Tylenol is that you don't want to drink alcohol while using Tylenol. Be sure to stay away from drinking alcohol while using Tylenol, because they're broken down into similar mechanisms, and that could cause you some pretty severe health issues. And you don't want to forget about the maximum dose, which is 4 grams in 24 hours. So if you look here, this is extra strength Tylenol, 500 milligrams each. So you do not want to take more than 8 of these pills every 24 hours. All right. The next way that we can manage pain after treatment is narcotics. What narcotics do are they're really strong analgesics. They're advocated for the most severe pains because they work deep into the nervous system, where they go deep into where the stem is, and they basically block those receptors from transmitting pain. The don'ts about narcotics, which I want to touch on, is their abuse. You abuse these. You want to use them over a really short period of time and only as needed and only as directed, because there really is a strong dependency potential, meaning you can get addicted to these drugs. As we all know, this is a serious problem in our country where many people are dying from the overuse of narcotics. And the main reason that a lot of people are dying, which kind of gets swept under the rug, is that narcotics cause severe respiratory depression. And if you're using too many of them, a lot of people mix them with alcohol as well, then that's just a recipe for disaster. So I really stress caution when using narcotics. They only should be used, as I mentioned, for severe pain. I actually have not prescribed a single narcotic in the last 5 years, and I do root canals for a living. So they only need to be needed in severe instances. There are other side effects that you don't want to ignore, as I've listed here. Nausea is one. Constipation is a really severe one. Also, drowsiness. They will make you sleepy, so use it with caution. Another drug that we use is corticosteroids. They're used to reduce the inflammatory response. Basically, on a scientific level, they suppress vasodilation and inhibit some different formations that cause that inflammatory process to continue. You don't want to ignore any possible drug interactions, so please let your therapist know what medications you're on. You notice I keep stressing that because there could possibly be some interactions when using these steroids. As Dr. Chan's kind of alluded to, there is an ideal analgesic for pain control, anti-inflammatory, as well as addressing fever. And that's combining Tylenol with ibuprofen. All right. So as I listed here, 400 to 600 milligrams of ibuprofen and 500 to 1,000 milligrams of Tylenol. So what I tell my adult patients, normal, healthy adult patients, if they can swallow the pills, it's 5 pills total. Basically, you're going to take 3 Advils and 2 extra strength Tylenols every 8 hours. Initially after the root canal for about 24 to 48 hours. After that, you shouldn't really need much as far as that goes. You might need some Advil here or there, but those first 2 days, usually after a dental procedure, are the worst, and the pain levels should be decreasing significantly after about 48 hours. If it's not, you definitely want to contact your dental professional again. But once again, that's 600 milligrams of ibuprofen and 1,000 milligrams of Tylenol. And if you're taking them all at once, I would do it every 8 hours just so you Tylenol schedule. Because remember, Tylenol, you don't want to exceed that maximum dose. This is something I really want to antibiotics disrupt bacterial growth. They're indicated for swelling or fever or signs of the infection spreading, like to your lymph nodes, or if you're an immunocompromised patient. Antibiotics are not for pain. They are not designed to treat pain. They may help with pain because of what they do for the bacterial growth, but they are not a pain medication. Please update your dentist if you have any type of allergies to antibiotics as well. And the one thing I definitely want to stress is you don't stop taking the course of antibiotics until it's completed, because that's what's leading to a lot of antibiotic resistance. Antibiotics are just being used. Oh, I used it for about 3 days. I feel better, doc. I stopped taking it. Or I picked up some antibiotics from Auntie Sue. She let me use some, for about 1 or 2 days. That's not a good idea because you're not taking the full course. So you're basically helping these bugs become resistant to the antibiotics. So take them as instructed and get them from a licensed professional. So in summary, the goal of pharmacological management of pain or medicines to help with pain both during dental treatment and after, you want to manage those symptoms with minimal side effects, no nausea, vomiting, or even dependency. Ideally, it's 600 milligrams ibuprofen with 1,000 milligrams of Tylenol every 8 hours. I want you guys to take that away from this presentation, if nothing else. If you use 600 milligrams of ibuprofen with 1,000 milligrams of Tylenol every 8 hours, that should be able to manage pretty much all dental-related pain. Anything after 48 hours that does not manage, you should have already seen your dental professional by then. Don't mix alcohol with any medications. That's the best idea. If you have any GI history, gastric issues, avoid all NSAIDs. Only take steroids if you absolutely need them. And as I stressed earlier, narcotics are something that should only be used when necessary because they have such downside. And antibiotic use to manage infections only. They're not for pain. Antibiotics are not for pain. And if you are prescribed an antibiotic, please take them as instructed until completed. I hope this provided some insight for you on how we like to manage pain from the dental perspective. If you have any questions, please feel free to contact me via email. Next will be Dr. Dana Jackson with pain associated with dental extractions. Thank you.
Okay, thank you very much. Let me see if I can share my screen here and pull up so everyone can see me. Okay, and we are going to talk a little bit about oral and maxillofacial surgery and pain management. And some of the things that I'm going to talk about, if you all can hear me, are similar to what my previous presenters have presented, because as we're in different specialties, I'm an oral and maxillofacial surgeon. We're best known for taking out wisdom teeth and putting patients to sleep and doing jaw reconstructive surgery. So some of the things that we do tend to be, especially hospital procedures, are a little more invasive, that may require a little bit more of an upgrade into the types of medications to control pain. But as far as what we've seen in the last 2 or 3 years is we've all switched from the narcotics to Motrin and Tylenol, as my previous presenters have stated, and have had very good results. There are occasions where we have to step it up a little bit and maybe use Tramadol, Vicodin, and or Percocet when we're doing completely full bone impacted wisdom teeth, and there's potential for pain that may override the traditional medications that we use. But as far as what we have done over the last few years, we have decreased significantly the amount of narcotics that we're using. And as has been stated, we have found that counseling the patient, letting them know that the medication we prescribe will work for them. Non-steroidals, ibuprofen, Tylenol in combination tend to work very well. So that what has been presented is very true. We have significantly diminished or decreased the amount of medication we use for pain as far as narcotics, but this is not something that we've eliminated altogether. So as we talk about, and we've all talked about how the patient perceives pain. Patients perceive pain based upon experience. They pay what they expect, whether it's from their family members who've gone through a procedure where they weren't fully numb and they've had tremendous pain, or they just come in so worked up. They tend to have different pain experiences based upon their previous relationships with either dentists or with the families that have to kind of work them up, especially with moms with children. Mom will tend to work the children up, so to make them think that it's going to be a lot worse than what it is. So what I tend to do is tend to have the parents just sit out of the waiting room, let me deal with the child, so I can talk to them, and they can hear the comfort in my voice. They can hear the confidence in what I'm going to tell them to do. I can walk them through the actual procedure, and they listen to me, and we go through it. It tends to be a much more pleasant experience. So pain is so subjective that once you begin to develop confidence with the patient, you as a doctor and you as a provider, it tends to be a lot better, because you can actually convince them through your discussion on what you're doing, what the potentials are, what you expect to see, and what the pain medication will do. You can actually make them more comfortable, and they will tolerate the pain medications better. And we have seen that in the last 2 or 3 years, where we decreased the narcotic number of prescriptions. Now, control of pain. You look at how you can control pain. You look at it before treatment, during treatment, and after treatment. So how can you control pain? It has been shown through research that if you give pain medication prior to the procedure, non-steroidals or even acetaminophen, which is Tylenol, non-steroidals or ibuprofen, Celebrex, and some of your other medications, even aspirin is non-steroidal. Then you can decrease the amount of postoperative pain, because these non-steroidal agents will prevent the inflammatory response. The reason why you have pain is because some of the mediators of inflammation tend, as the body tries to respond to an insult, tend to cause more discomfort. So if you can give it prior to the procedure, then it can actually help the patient in having less postoperative pain, so that you don't have to worry about the long-term or the first 24 to 48 hours of having a lot of discomfort. So, but that's before treatment. Now, during treatment, of course, you have to manage the pain. And the biggest thing, we put a lot of patients to sleep. We take out wisdom teeth. We do a lot of surgical procedures, implants, etc. You have to manage the pain during the procedure, because if you don't know how to give good blocks, or you don't give blocks that really make the patient feel very comfortable, all the patient should feel during surgery is pressure if they're awake, and which is pushing and the touching around the tooth. They should not feel sharpness. And if you're able to give a variety of blocks, which is beyond just the traditional blocks, you can give B2 blocks, you can give Gal gates, you can give Akinosi blocks, which will block the entire nerve. Those are things that we can do to make the patient more comfortable, especially with an inflamed tooth. We have an inflamed tooth that is what we call a hot tooth. Then you have to have techniques beyond the traditional injections to make that patient numb. And it may include periodontal ligament injections. It may include intraosseous injections. It may include a traditional, not outside of traditional block, may include a block that may block the entire nerve, like Gal gates would block the entire third division of the trigeminal nerve. Or if you can give a greater palatine injection through the canal, you can get an entire second division nerve. And what I mean is that you block the entire nerve, and you can assure the patient will be very comfortable during the actual treatment. So the ability to do a variety of injection techniques is a part of what we do as providers, in addition to offering the sedation or IV sedation or general anesthesia component that allows us to actually manage pain. Now, after treatment, the pain associated with procedures is most commonly related to how invasive the procedure is. If you can get in and get out with minimal invasion, you tend to have less pain. The longer the flap is open, longer the tissues are open, the more surgery required to take the tooth out or do the procedure, you tend to have more pain. So as a provider, you want to be able to get in, get out, provide the procedure, and minimize the time of the procedure. That tends to decrease the postoperative pain the patient experiences. And you always prepare the patient by having prescriptions. I always have prescriptions prior to, because I normally consult with my patients, because most of my patients go to sleep. So I consult with them prior to, and I give them prescriptions in advance. So they already have the prescriptions. And even if they're going to sleep, they have their prescriptions in advance, so they can take their prescriptions as soon as that numbness begins to wear off. So they're very comfortable with their postoperative course. And as you talk to patients about their pain experience and about their dental experience, it tends to work well if you understand what they've been through, and you actually prescribe based upon what you feel is the pain experience they're going to have, as well as what you think that will make them comfortable in the long term. And there's a psychological component to what we do, where just the discussion and the confidence they feel in the provider that helps to make the patient tend to be more comfortable with what we do. Now, we've talked about this with the previous doctors that have done an excellent job just talking about the psychological components, the physical components, and pharmacological methods of controlling pain. And it's in combination, and everybody's different because of different experiences, different professions. We tend to see patients as emergencies as oral and maxillofacial surgeons. They come in with either severe infections where they have an infection that may be spreading, or they have a toothache that that's not controlled, which is normal injection techniques. They need to be put to sleep. So we have a different mechanism of controlling the pain, but it's very similar. And all we're doing is building upon what is done by our other professions, other specialists within the profession. And we may have stepped it up, but it depends on what the actual agent that's causing the pain. Is it a toothache? Is it a bacterial infection? What is it that's actually causing this patient to have pain? And so we tend to target our procedures as to what we can do to minimize the patient's discomfort, get that procedure done, and then manage the postoperative discomfort the patient has. There are times when you may think it's best to just put the patient on antibiotics, let the actual infection resolve, makes the local anesthesia a lot better, and then you go in and do your procedure. There are times when it's an emergency where you have to do it right then and there. And so you have to have the ability to modify your techniques based upon the seriousness of the patient's condition and what is best for the patient at large. So those are the kind of things that we kind of manage, and it involves a lot, the whole understanding of the gate control theory of pain, all of the things of how pain occurs. We have to have an ability to give anxiolytics, sedatives, and other medications to make the patient more comfortable, because everybody has fear of the dentist. Most of the patients come in. And so what we do as surgeons is try to give the patient options: local anesthesia, nitrous oxide, laughing gas plus local anesthesia, or light sedation, general anesthesia, also with local anesthesia, are things that we can do to make the patient's pain experience a little bit better. So, and we've talked about this. The previous doctor was very well, talked about the different medications we use to control pain, and we're all in the same profession. We all use the same types of medications, and depending upon what the need is, you prescribe based upon what works best, based upon what you're providing to the patient in terms of treatment. For TMJ patients, we use anti-inflammatory agents. We use muscle relaxants. We may use antidepressants. For patients that have a history of allergies or they react, you can give antihistamine like Benadryl that will not only reduce the chances of allergic reaction, but also sedate the patient. The antidepressants that the patient may be taking, we can supplement those. Some of the things that we use for sedation are in combination with the patient's already taken, so we have to be very careful. We don't take them over the edge. But there you have a variety of agents out there that you can utilize to manage the patient's pain, but you have to pick the one that's the best and the most appropriate for the situation that you're dealing with. And we've talked about some of the natural painkillers. Some people ask you, well, what can we do at home? Now you can use the biggest one that we use is that we use, because we use it for dry sockets, and dry sockets is when you have a tooth taken out and you lose the blood clot, and what happens is the free nerve ending is exposed. So you can put oil of cloves within the site. This comes in as liquid, and that will help to numb the site, to buy time for that area to granulate over and to begin to heal. So the exposed nerve endings will begin to be covered by the normal healing process. Normally with dry sockets, you pack them. They come back in 48 hours, and you see how they're doing. You may pack it again. By the time you pack it once or twice or 3 times, then the body has the ability to cover over the exposed nerve ending and to make it better. So these are, but you can do naturally with oil of cloves. So some of the other medications you see here are for different types of pain, and you have to, as providers, we have to recommend over-the-counter things the patient can do, and we're going to talk about a few of these things that we can do, or we can prescribe to the patient. One of the things that has been mentioned, aspirin. Aspirin, people tend to put it in the mouth, and is very acidic, and it causes erosion of the soft tissue, and it can cause sores that can develop in the mouth. So aspirin is not a cure-all or treatment for intraoral pain. Aspirin is non-steroidal, and it can be used orally as to swallow, but it's not a topical application that can be used to control pain. Pain medications, the opioids we talked about, narcotics, which we have decreased, but we have not eliminated. We have decreased them. Non-steroidals, ibuprofen, which is the most common, which is Motrin, and most of us know about that. Tylenol or acetaminophen is very good. Tylenol is not anti-inflammatory, so it's not a non-steroidal, but it is good for pain management. It works by a little different mechanism, and it's good for fever, as the NSAIDs are. So if you tailor your medication to what they do best, then sometimes patients can't take non-steroidals or Motrin, can't take Tylenol, and you can get pain relief from the actual prescription that you provide. Topical anesthetics, Oragel, and mouth rinses like viscous lidocaine and chloroseptic mouth rinses also can be used, and we'll talk about those. Now, pain of odontogenic origin, which means pain that's associated with a tooth. And as you can see here in the slide, you have a patient that has class 5 or areas of carious lesions in the area of the tooth that's closely associated with the gums. Now, if this caries is intimately associated with the nerve or the pulp chamber, then you can have serious pain associated with this. So what do you do for this? The most important thing you can do is to treat the problem. Remove the caries and put a filling, temporary filling or permanent filling to relieve the issue, or do root canal. But in the meantime, you have to have an option until you can get them into the office, because most offices are very busy, and for procedures that require, and this patient would need a lot of time because it has more than one issue, you have to be able to give them something. So antibiotics are effective because the bacterial infection that is caused can help to cause the pain perception and reaction the patient has. It's not a total cure of everything, because you have to treat the cause. But antibiotics, in addition to the pain medications, can hold the patient, at least temporarily, because decreasing the inflammation, decrease the bacterial, the multiplication of the bacteria and the effect of the bacteria can help to hold that patient until you can get him in for definitive treatment. So I look at patients that have, pericoronitis, which is inflammation around a third molar that's partially erupted. And there are some times where the tooth is so hot, where the pericoronitis causes inflammation. What I do, I irrigate the patient. I put him on a antibiotic. I put them on an analgesic, and I bring them back in 2 or 3 days when they settle down a little bit. And it's easier for the patient to be numbed and it's easier for the procedure to be done. They heal a lot better. So you have to be able to calculate what is the best treatment and understand what can be done to minimize the discomfort, decrease the inflammation, and make things better for the patient as far as their short-term as well as long-term pain. Wisdom teeth. Wisdom teeth are the most common reasons that we take out teeth in the mouth is because you have third molars, which are called wisdom teeth. They're all the way in the back that are not coming in. The jaws are developing smaller because of evolution, and they don't always come in straight, or nor they come in where they contact each other. So with wisdom teeth pain, you have to decide on whether or not the tooth is going to be beneficial to the patient or whether it's going to be a problem down the road. So as we take teeth out and we assess people with wisdom teeth, we look at the teeth. Are they going to come into occlusion where they bite with the opposing tooth? Or they can come in where they're able to function, or are they going to push the teeth either forward or cause problems, almost as a teething type of pain like you see in children when they're trying to come in, or are the teeth going to be problematic down the road? And oftentimes we're seeing they would be problematic. We recommend at an early age, anywhere from 18 to 22 or somewhere around there, where if the wisdom teeth are going to be in the mouth and functional, that we take them out to minimize problems down the road. And if the teeth come in and they're fully erupted and they're functional, then we just observe. But most oftentimes the jaws aren't big enough to allow the wisdom teeth to come in. So we have to interact, and we have to try to alleviate the problem before the roots are fully formed, because as they become more fully formed, they're closer to the nerve of the lower jaw nerve or to the maxillary sinus on the top. So we have to kind of make that decision as to what is best to manage the patient's long-term pain. And so we utilize the knowledge of eruption, knowledge of anatomy, knowledge of the teeth and the importance of the teeth to determine whether or not we recommend extractions, or whether we observe and wait. Those are the kind of things we discuss with the patient individually, because everybody's situation is different. Oragel, I think some of the doctors have mentioned, it's a topical where you can put it directly on the site. And if the it's a numbing medication, a topical medication, benzocaine, if it can touch the site where it's causing the pain, it can help you. But if the pain is deep, it's not going to really help that much. But a lot of patients utilize that when they have toothache pain. Sometimes it helps them, sometimes it doesn't. But it is something that can be beneficial in the short term until they can get in for definitive treatment. We talked about TMJ pain, and this is non-allergic pain. The TMJ or temporal joint is where the lower jaw has been mentioned, come in contact with the skull, and it's affected by the muscles that allow you to open and close the jaw. The teeth and the way the teeth come together is affected by stress and function, parafunctional habits, and all those kind of things. It has to be a balance between everything. So if the balance is in place, then you tend to be able to work very comfortably with your jaw as far as opening, closing, chewing, and eating and speaking, those type of things. When there's a balance of the bites, of the teeth, the jaw muscles, you may have some traumas in the joints and the stress associated with it, then you can have TMJ problems that can cause referred pain. Referred pain is where you have pain in one area that's referred to other areas. That pain can refer to the neck, the eyes. You can have headaches. You can have throat pain. You can have neck problems. You can have earaches associated because all the nerves tend to run together. So identification of the source of the problem and identification of how to best remedy that patient situation is very important for the doctor. So a full workup is important in terms of determining where the pain is coming from, what are the associated factors with the pain, targeting your treatment towards relieving the pain by preventing the patient from traumatizing either the joint, the teeth, the relaxing the muscles, or decreasing the inflammation in the areas of the joint, or depending on what the situation is. So the ability to diagnose that is very important, and that's what we do as dentists and specialists to manage the patient's discomfort. And this kind of just shows you what we're talking about. Sometimes the TMJ you treat with anti-inflammatory agents, you treat with Tylenol, muscle relaxers, hot and cold stretching exercises, TENS units, which is like electric current. You actually shoot to the muscle to relax it. You can do jaw realignment where the jaws aren't coming together properly. You can reposition the jaw surgically. And then there's a number of procedures that we can use to create a better balance between the upper and lower jaw and the muscles that help to control the joint that can make the patient better off. This is the TENS unit. We often refer patients to a physical therapist that will have these units, but you can also buy these at home. And these will send electric current into the muscles when you have a problem with muscle dysfunction, mild facial pain dysfunction of the joint. You can put these probes on the actual jaw, send a current through them, and it will relax them temporarily to give you some relief. Now, it doesn't solve the problem, but it does allow you to relax the muscles so the patient can actually get some relief from the discomfort that they're having. And these are used, frequently for not only for the TMJ, but for when you have back problems and problems with your legs and your thighs and you're getting cramping up in those things. These are what are recommended by a physical therapist to bring you back into a normal relationship, or at least relieve some of the painful discomfort. And this is what we do for the TMJ. Now, trauma. Now, you have non-adgenic sources of pain. You may have trauma. You may get punched in the jaw. Now, when you punched in the jaw, your jaw breaks. The jaw is just like any other bone in the body. You have to, if the jaw is broken, you have to put the points of the jaw would have been broken back into position. You have to realign the teeth. And if you do that, just in doing that, that will help to relieve the pain. So part of the treatment of painful dysfunction associated with a trauma and a broken jaw is putting the bones and the teeth back into alignment. Now, once you've done that, then you can use your traditional pain medications such as non-steroidal anti-inflammatory agents, acetaminophen. Sometimes use the opioids, and of course use antibiotics so the patient doesn't get infected. But if you don't reposition the jaws to normal relationship, the patient is in pain because they're out of position. So the first line of treatment when they come into the emergency room and have a broken jaw or come into your office is to put the jaws back to where they're supposed to be. Now, that may result in being wired for 6 weeks, because any bone in the body that breaks, it has to be stabilized either through a plate or through the teeth being wired together for 6 weeks to allow the bones to reheal. So that is understanding of the anatomy of the jaw bones, the physiology of bone healing is very important to allowing us to get that patient back and up to function, reestablishing the bite, reestablishing the bone, the anatomy of the bone, and also the continuity of the bone to allow them to function after the broken jaw is treated, so that after it's treated, you can get back to normal function and get them out of what acutely is a painful situation at the time of the actual trauma. As far as lacerations, we see this is also a non-adgenic source when you see patients that have been in fights where they've had soft tissue laceration. The first thing we want to do is reestablish the continuity of soft tissue. So you do your closures to bring not only the deeper tissue together, but also the superficial tissues of the skin together, reestablish it. Once you do that, then you just manage the patient through either antibiotics and the non-steroidal agents to control the pain. But if you don't put the soft tissues back together, then they tend to bleed. And of course, the more inflammation, the more of the inflammatory mediators that can continue to cause pain can be in effect, and that can cause problems with the patient's perception of pain. Now, there are also other issues, other situations in the mouth that can cause pain. You can have oral cancer. The most common area of oral cancer is lateral border tongue. Squamous cell carcinoma inside the mouth is most commonly on the side of the tongue, lateral border tongue. And so part of our oral examinations, we look at those areas to make sure those areas are stable, and to make sure that those patients, if they do show evidence of any kind of lesions on the side of the tongue, we biopsy those areas as soon as possible. And then if they do show signs of squamous cell carcinoma, we refer them very quickly to an ENT surgeon or to a tumor team or pathology team that can manage their situation. But as dentists, we have the ability, because we look in the mouth, we understand the mouth, we know what's normal, we know what's abnormal, to identify what's right, what's wrong, and what needs to be done to either diagnose and or correct the problem. So those are things that we will notice as part of our oral examination. There are other pathologies in the mouth. You can have cysts and tumors of the jaw. And if you look over here on the right side, you see all this large area of darkness that's surrounded by this white line. That's a cyst and or tumor of the jaw. And this patient will have either pain or they may have numbness, because you have a nerve that runs down through the jaw that may be affected, where they may not be able to feel it, but they may have pain because of swelling. So as part of your examination, you do a radiographic examination to determine what you see as far as the bone. X-rays show you the bone. You do intraoral examination and see the soft tissue to see what's going on there. So sometimes you see the soft tissue are expanded. Sometimes you see the soft tissues are normal. Sometimes you see, with the X-ray, you see a large, what we call radiolucency or darkening of the bone that's associated with the tumor. So it's part of our examination to determine what the painful source of the problem is. We have to do X-rays and or clinical examination to determine what is the problem, why are they having pain, and what needs to be done to treat this. And this may involve enucleation or removal of the tumor, or may involve other procedures to decrease the size of the tumor over time, like a marsupialization, or other things that can be done to manage the actual patient's tumor. As far as other soft tissue injuries or soft tissue areas of soreness, canker sores are very common. And these are normally related to stress and or trauma to the mouth, where you have a sore on the soft tissue of the oral mucosa, and it tends to be very painful. But the thing is, it only lasts if that is after it's also a canker sore, it lasts about 10 to 14 days and it goes away. So what you do is try to manage it for the patient to take away the painful situation for at least that time until it goes away. One of the things we found works very successful with these type of lesions is Kenalog and Orabase, which is a combination of steroid with a chemical that will help to numb the area and keep it very comfortable until the area until it actually heals and goes away. With no treatment, it goes away in 14 days. If you treat it, then you can make the patient comfortable until it goes away. So this can be a very effective mechanism of pain management when you have these oral ulcers or canker sores that are very, very common. Now, the etiology and why it occurs, some suggest autoimmune factors, but stress trauma is not well known. But when it comes, treat it very conservatively, but with the understanding that in 10 to 40 days is going to be gone. Keep the patient out of pain. And you can not only use Kenalog and Orabase, but you can use magic mouthwash and other types of things to numb the mouth, which we'll cover in just a few minutes, that can also help with these type of situations. Oragel, once again, is very useful in some of these types of disorders, soft tissue pathology disorders. The other is oral rinses. Viscous lidocaine is the same numbing medicine used when you give an injection. Lidocaine is what we use to numb the jaw for extractions and other things. But you have a viscous mixture that is more concentrated you can actually rinse with, that will help to numb the mouth, and that will keep the mouth numb for 25 minutes, and it will give you some relief, especially if the patient needs to eat. And you say, well, look, let me just swish for about a minute, and you don't swallow, you swish and spit it out. And that allows that patient to be numbed long enough for them to either eat some food or get some relief from the severe pain they're having inside the mouth. The other thing, the other medication is chloroseptic, which has been around forever. We used it as children when we had sore throats. And with chloroseptic, we used to rinse and then swallow. And if you had a severe sore throat, it helped to numb it for 10, 15, 20, 30 minutes until it felt better. Now, it doesn't solve the problem, but it gives you relief. So these are things that can be obtained through the pharmacist or over the counter that you can utilize to decrease the painful experience. You can also use, the oral lozenges. When you have a sore throat, they give you oral lozenges to kind of suck on oral lozenge. That can help you because it helps to numb the area enough to give you some relief. From the sore throat, it doesn't cure it, but it just helps you during the short-term period. One other thing is trigeminal neuralgia, non-adgenic pain. The trigeminal nerve is the nerve that supplies the upper face, the mid face, and lower face, and including the teeth. And when you have these sharp shooting pains, it's a nerve pain that's different from a toothache pain, and that it fires. It fires for a short time, very, very, very hard. So you tend to have a lot of pain, and it's something that you need to differentiate differentiated from toothache pain, but it can be something that can be very, very, very traumatic for the patients. There are different ways to treat it. You can use anticonvulsant medications, muscle relaxers, radiation therapy, and you can use surgery also, and thermal treatments to help to relieve that type of pain. But the responsibility of the providing a dentist and or specialist of dentistry is to diagnose the problem and identify it as a nerve problem or as a tooth related problem. So if it's tooth related, then of course you treat the tooth in question. If it's nerve related, then you have to assess what nerve is involved, what branch of nerve is involved, and then refer them to the appropriate specialist to manage. Sometimes it's a neurosurgeon, sometimes it's a neurologist, sometimes it's a neurosurgeon. It depends on how severe the disorder is. And finally, when you have a procedure where you're doing surgery to remove all 4 wisdom teeth and you're doing other procedures and you want the patient to stay numb for a longer period of time, you have the opportunity to give Marcaine. Marcaine is a long-acting local anesthetic that will give you 6 to 8 hours of pain relief and numbness. The normal lidocaine injection will last about an hour and a half. This will give you a longer period of time that will give you an opportunity to either get your medications in order to control your discomfort or give you time to get your ice on and to do things to before the numbness wears off. So these are different things that we can utilize in terms of management of pain to help the patient out. And these are commonly used after wisdom teeth removal or after a major surgery procedure to help the patient to give them time before the numbness wears off so they can get their pain medications in order. The most pain clearly is within the first 24 hours. The first 8 to 10 hours after the numbness wears off, you have your most pain. So if you can keep that patient numb for an extended period, then you can get them through the most critical period. And then you can manage them with your other agents after the first 8 to 10 hours much more effectively. So this is a very important and effective way to treat the patient's pain. So in saying that, I would defer and allow Dr. Watson to come back in and present. And this is just from an oral surgeon's point of view, how we look at pain, and how we actually manage pain.
Compilation of his and presented both of his at the same time. So he did a continuum there. And okay, but that wraps up our discussion. I want to thank our panelists for taking the time to prepare this very extensive presentation on dental pain. Because of time, we'll only take a couple of questions. And so this one can go to either the endodontist or the oral surgeon. Do you use a different technique if a patient is hard to numb due to infection?
If I can take this as a oral surgeon, Dana Jackson, yes, we do, because the environment has changed with the infection. It creates an acidic environment. It makes the local anesthesia not as effective. So you have to use alternative techniques to change the environment back to a more stable, more basic environment so you can get the patient numb. They may include infusing a more local anesthesia into the area, the lidocaine that we normally use, or maybe a different type of local anesthesia, such as Marcaine or Ceticaine, to put it in the area to kind of change the environment so that the patient gets numb and you're able to treat the procedure. Sometimes you're not able to do this. Sometimes you put the patient on antibiotics and bring them back. But you have to modify your technique based upon the patient's presentation. We have the ability to get the patient general anesthesia, IV sedation, put them to sleep, which makes it easier for us to manage the case. But sometimes on a local level, you try to flood the area with more local anesthetic agent, and then if that doesn't work, either through PDL, periodontal ligament injections, or different types of blocks that you can get more of, the mandibular blocks or maxillary blocks that we use, then that can be effective. But you have to modify your technique, otherwise the patient won't get numb and they're going to be very uncomfortable during your treatment of them.
Okay. Right. This question can go out to anyone that would like to take it. It's a two-part question. What are the symptoms of serious dental pain, and when is dental pain serious?
I'll take part one of that from the endodontic perspective or the nerve perspective. The symptoms are going to be mainly spontaneous, lingering, sharp pains that are usually stimulated by temperature or even biting forces. Those are going to be your first signs of actual tooth pain, nerve pain. And then once it spreads, if you do have a tooth that becomes necrotic and it becomes a bony involvement, then you may have swelling, lymph node swelling, trismus, trouble opening, closing your mouth. Those are going to be your main indicators of dental related pain. As far as pain becoming serious, the second part, I think we all will kind of agree on that. Pain is subjective, so it's serious when it's serious to you.
Yeah.
Okay.
I
fully agree. Dr. Anderson?
I might add a little bit. Pain is serious when it limits the person's ability to function normally, meaning if they cannot eat or if they can only eat on one side of their mouth because the other side is hurting. Also, if it's serious, if you can't go to sleep, if it keeps you up hurting at night, that's serious. That's serious pain. Because pain is subjective, some people can tolerate it and some people can't. I think all pain is serious because it's telling your body is telling you that something is wrong. The only time that the body experiences pain and something is not wrong is probably during childbirth. We don't deal with that part of the body, but that's serious pain that doesn't necessarily tell you that something's wrong. But in the mouth, if you have pain, that means that something is wrong and it should be addressed. It may go away, but the idea situation is to get to a dentist or a medical doctor and have them evaluate the situation. And as I said before, the best cure is prevention. Getting in to see your dentist on a regular basis, having an examination to catch things before they become painful will reduce, a lot of challenges that people would have and make life better.
Right. Thank you. This question, and with the final question, is not a pain question, but it is one for Dr. Chance. Dr. Chance, how do you feel about mobile and school-based sealant programs when access to dental care is limited?
I'm a huge fan of them. We did a lot in dental school and in residency. When done effectively, it can really help that access to allow for kids to be seen in an environment that they may not be seen at home. So there's some scenarios where parents or guardians may lack the ability, may lack the finances, may lack the understanding of the importance of dental care, and getting children seen where they are is a wonderful adjunct to the treatment that we're able to give them naturally. So I'm a huge fan of them. I believe that access to care is a huge undertaking, but it is absolutely important, and one of the main reasons why we're having so many issues with dental pain, dental infections, loss of school in regards to kids missing school because of pain and infection, misbehavior because of pain and infection, maybe not able to express themselves, so they can maybe lash out and how their behavior could be. There's so many things that can be tied to that. And if we can prevent that as much as possible, we can set our kids up for success for the future, for sure.
Right. Thank you. Thank you very much. And again, let me say to our panelists, thank you so much for sharing your expertise and your time. Putting these presentations together is quite time consuming. And so we want to thank you for sharing that. To our viewers out there, we want to thank you for joining us tonight. we hope that you have picked up some gemstones that will help you in your management of your dental care. Our Surgeon General, Dr. Jeffrey Sterling, is not with us tonight. He has to work in the emergency room, and so therefore he bids hello to all. And so I want to thank everyone for taking the time from your schedules to join us. And so we now say good night to all, and thank you very much for having joined us.